Welcome, dear audience, to another international session of our ophthalmology learning programs. Today, we are going to discuss about thyroid eye disease, and we have requested an expert, a consultant in this field who has extensive experience in the management of thyroid eye disease. I'm talking about Dr. Sunja Mansfield Smith. She is the lead of medical ophthalmology at Ipswich Hospital, NHS, UK. Her team is instrumental in diagnosing and managing complex ocular diseases and takes a multidisciplinary approach to the management. She primarily works in coordination with endocrinology, rheumatology, infectious disease department, neurology to achieve optimal outcomes for her patient. So today we have requested her to please guide, educate our international audience about this very challenging topic of thyroid eye disease, how it's being diagnosed, its pathophysiology, the current and latest trends in the management. So without further delay, I will request her to please present her talk.
Thank you for your kind introduction, Professor Misra. It is really an honor to be here and present on such an interesting and dynamic topic, the medical management of thyroid eye disease, current and emerging therapies. I'm going to firstly talk about the background to thyroid eye disease and give a short overview of its pathophysiology, then move on to the focus of this talk, which is the medical treatment of this condition, discussing current guidelines, particularly the European Group on Graves' orbitopathy guidelines and emerging therapies. For context, these are the key time points in the history of thyroid eye disease. The first documented case was by a Persian physician, Dr. Al-Jajani, in 1110 AD. Almost 700 years later, Dr. Graves clearly described the link between an enlarged thyroid, palpitations, and protruding eyes. Interestingly, he was a keen educationalist with a focus on the importance of bedside teaching. His ideas regarding medical education spread across his native island and beyond. About 100 years later, in the 1940s, synthetic steroids were first created, and in 1945, Rundle and Wilson published the forerunner of Rundle's curve, which was inverted from the one we now see in modern texts. In the 1950s, there was the first documented use of steroids in thyroid eye disease. And in 1956, Adams and Peirce discovered the TSH receptor antibody, proving the underlying condition is autoimmune in nature. Now in clinic, when considering treatment plans and future therapy targets, it's important to understand the key immunological aspects of thyroid eye disease, their anatomical consequences, and the principal deductions of clinical assessment. There is an overexpression of TSH receptors on the orbital fibroblasts in thyroid eye disease patients. Their activation, either by excess hormone or antibodies, results in the differentiation of orbital preadipocytes into adipocytes with consequential orbital tissue expansion. IGF-1 and its receptors are overexpressed on a multitude of cell types in thyroid eye disease, leading to orbital fibroblast proliferation and cytokine secretion. There is interaction between these two receptors, which are co-located on cells. As seen on the orbital fibroblast image, there are a multitude of cell types and receptors involved in thyroid eye disease. Many are the targets of current and future therapies. These biochemical factors leads to anatomically an expansion of rectus muscles and fat. The cone enlarges circumferentially until it is arrested by the orbital walls. Extraconal fat can be displaced forward. There is axial advancement of the globe, increasing cone pressure, which can impede venous flow, edema of extraconal fat and eyelids, and these anatomical changes lead to the various clinical signs of thyroid eye disease. Rundle's curve is a useful geographical representation of the natural history of thyroid eye disease over time, showing its biphasic pattern of active and stable states. Current medical therapies are aimed at the acute and active phase, but emerging and future therapies may not only help in this phase, but later in the disease process. Treatment decisions are based on assessment of clinical activity, severity, duration, and the orbital components involved. The clinical activity score is a simple, validated scoring system used to assess disease activity. The severity of thyroid eye disease should also be classified, and it can be subdivided into mild, moderate to severe, and sight-threatening disease. Finally, duration helps indicate where the patient may be in the course of the disease process. With the medical management of thyroid eye disease, there are some general recommendations. We know that smoking drives thyroid eye disease and worsens the prognosis. So quitting smoking is not just a lifestyle recommendation, but is a key part of a patient's treatment plan. Restoring and maintaining euthyroidism is associated with thyroid eye disease stabilization and improvement. High LDL cholesterol levels are associated with the less favorable response of thyroid eye disease to IV glucocorticoids, and dyslipidemia identification and treatment is recommended in these patients. Patients can be managed in an MDT setting. Locally, we have weekly thyroid eye disease clinics and bi-monthly MDTs with orthoptics, oculoplastic surgeons, endocrinologists, and myself. Other recommendations in mild thyroid eye disease also include selenium supplementation. Relatively lower selenium levels have been shown to have a modest correlation with severity of thyroid eye disease. Selenium supplementation has shown some benefit in patients with mild disease. Usually, immunosuppression is not required, with a few exceptions, and these patients may still benefit from rehabilitative surgeries later on. For moderate to severe and active thyroid eye disease cases, the UGOGO guidelines recommend IV methylprednisolone, 500 milligrams weekly for 6 weeks. Then, if patients are responding, to decrease to 250 milligrams weekly for 6 weeks, along with oral mycophenolate, a traditional DMARD. When using this regime, the side effects of steroids need to be mitigated and managed for each patient. Alternatively, a higher dosing regime of IV methylprednisolone can be considered. If patients are poor responders, then second-line treatments are potential alternatives. These include a second higher course of IV methylprednisolone, oral prednisolone and cyclosporin, azathioprine, radiotherapy in selected cases, teprotumumab in countries where it is available, rituximab or tocilizumab. Sight-threatening thyroid eye disease occurs in a minority of patients, around 4%, due to either dysthyroid optic neuropathy or exposure keratopathy. In patients with DON, they need management with intense IV methylprednisolone pulses, 500 milligrams to a gram on 3 consecutive or alternate days, with close monitoring of ophthalmic parameters. If there's response, they can continue on IV methylprednisolone, or if there is no response or deterioration, they need urgent surgical decompression. In cases of exposure keratopathy, other procedures may be necessary, such as a tarsorrhaphy. DMARD. So mycophenolate is a first-line recommendation. It's a traditional DMARD, which means disease-modifying anti-rheumatic drug, and it's a prodrug of mycophenolinic acid that inhibits type 2 inosine monophosphate dehydrogenase, the rate-limiting enzyme in de novo GTP nucleotide synthesis. This enzyme is expressed widely in activated B and T lymphocytes. MMF attenuates the action of IL-2 and IL-1 beta. Its cellular targets are broad, leading to wide scope of immunological consequences. In both these randomized trials, mycophenolate-treated groups demonstrated superior response rates at 12, 24, and 36 weeks compared to their retrospective glucocorticoid monotherapy groups. This is now why it is a first-line recommendation. Azathioprine, another traditional DMARD, is a second-line recommendation. It's an anti-proliferative agent with similar modes of action to mycophenolate, and it's a second-line treatment option in combination with oral steroids and was shown in one RCT to decrease relapse rates. Cyclosporin interferes with IL-2 release and expansion of lymphocyte clones. It blocks pro-fibrotic cytokines, aborting the cicatricial phase of thyroid eye disease. Compared with drugs like mycophenolate and azathioprine, we know it's quicker acting. However, it has a wider side effect profile, including higher risks of diabetes and hypertension. And remembering you're giving this drug alongside steroids that have the same risks. It also requires careful serum drug level monitoring. B cells also play a part in the pathogenesis of thyroid eye disease. Rituximab is a chimeric human and mouse monoclonal antibody against CD20 surface antigens expressed on B cells that causes immunosuppression through B cell depletion. Retrospective case series have suggested benefit in thyroid eye disease. However, there were two double-blinded, low-powered, single-centered RCTs showing conflicting results. One US study showed no benefit over placebo. An Italian study showed better ophthalmic and quality of life outcomes in the rituximab group, but infusion adverse events were noted. It's a second-line recommendation in patients with thyroid eye disease, but should only be used in experienced centers which can manage potential reactions. Tocilizumab is a humanized monoclonal antibody against interleukin-6 receptor. We know that serum interleukin-6 and IL-6 receptors in TED patients are higher than in controls and correlate with thyroid eye disease activity. IL-6 also acts directly on orbital preadipocytes to promote volume expansion. Current data suggests that tocilizumab may cause rapid resolution of inflammation in glucocorticoid-resistant moderate to severe cases which are active. And it's recommended as a second-line treatment in these patients. So clinically, what we're seeing is a move towards more targeted therapies, and this is also reflected in research and ongoing trials. The therapeutic benefits of targeting IGF-1 receptor has been documented in the OPTIC study. This showed teprotumumab, a monoclonal antibody that binds to IGF-1 receptor and blocks its signaling, leads to significant improvements in proptosis, clinical activity score, and diplopia response. The effect of teprotumumab was rapid for each outcome and was shown even at 6 weeks, and continued improvement was noted over the 24-week treatment period. It has also shown benefit in later stages of thyroid eye disease. However, it's not without side effects. Initial results showed hearing impairment in around 10%, and later data suggests this occurs in approximately 30% of patients. It can cause worsening of IBD, it's contraindicated in pregnancy, and can result in transfusion-related reactions. What this medication has demonstrated is that clearly targeting IGF-1R is of therapeutic benefit in thyroid eye disease and is the focus of ongoing research in the management of this condition. Potential future therapies include lonigutamab, which is given subcut or IV, and it binds to IGF-1R from the surface of cells and induces internalization and degradation of IGF-1R, thus potentially blocking IGF-1R signaling. Veligrotug IV also targets IGF-1R and is a full antagonist of this receptor. Lizitinib inhibits IGF-1R and insulin receptor, significantly reducing T cells and macrophages in the orbit. Another potential target of future therapies is inhibition of the neonatal fragment crystallizable receptor FNRC, resulting in decreased circulating TSH receptor antibodies. Interleukin-11 is another therapeutic target in thyroid eye disease, as it's a fibroinflammatory cytokine elevated in patients. It drives the abnormal tissue expansion in the orbit. Therapies blocking the IL-11 receptor are being developed to inhibit this pathway, aiming to reverse thyroid eye disease sequelae like proptosis and inflammation by stopping IL-11 signaling. Research into these and other targets is ongoing. The key take-home message for the direction of medical management of thyroid eye disease is that we are witnessing a shift away from broad immunosuppressive therapies, such as systemic corticosteroids with their multi-system adverse effects, towards targeted treatments aimed at optimizing clinical outcomes We really are now entering a dynamic and exciting period in the evolving management of thyroid eye disease. Thank you.
Well, Dr. Mansfield, it was a very nice and practical approach presentation in which you highlighted the current trends and the treatment, how it can be managed. Just a few things I want to ask you about the management of this very challenging field of thyroid eye disease from your experience. How do you approach the medical management of active, moderate to severe thyroid eye disease in patients who are, I mean, not tolerant to the corticosteroids? And we also know the second part I will add, doctor, to it is about European group of Graves' disease or myopathy. Suggests that intravenous corticosteroids are recommended, better tolerated. So, what is your experience about the adverse effects?
Thank you. There's some great questions there about the use of steroids in thyroid eye disease. So, firstly, about patients being intolerant to steroids. So, firstly, I would look at the mode of delivery. If a patient who is intolerant of oral steroids may have less side effects on IV steroids, so you could switch there. Otherwise, if they really are intolerant to both, then the systemic steroids could be stopped and they could be continued only on mycophenolate with close monitoring. Or if they have more severe active disease, we could look at starting other medications like tocilizumab through an independent funding request. Or in sight-threatening cases, we would need to plan for urgent surgical decompression. Yeah, they would be the other approaches that I would take. As for the side effects on IV methylprednisolone, we know that steroids can produce a multitude of side effects, but the most common ones I see in clinic and that patients tell me about is that after each pulse, they have disturbed sleep for a night or two, and they often experience mood changes. Biochemically, we see that patients' HbA1c can rise during treatment. So particularly for diabetic patients, they need close monitoring with their GP or endocrinology team to ensure that this is controlled. Thank you.
Well, thank you, Dr. Mansfield. One thing more I want to ask you about the conventional use of steroids or using biologics. How do you make sure the safe prescribing and appropriate ongoing monitoring in such patients?
Yeah, that's a very, very important point. Regarding steroids, we would do baseline bloods for all patients. Patients with a cardiac background, we may also check things like an ECG, chest X-ray. With DMARDs, there's also set blood tests that we do before commencing patients on, say, mycophenolate. And they also need ongoing monitoring while they're on this treatment. In the UK, the specialist prescribing mycophenolate remains responsible for the monitoring of this for patients with thyroid eye disease, as it's not covered by a shared care guideline with a primary physician. You do need a robust system to ensure safe prescribing and monitoring. Here, we keep a database of patients on immunosuppression, and I have GP trainees working in the department with me who are experienced in interpreting blood results and understand the schedule of monitoring for these patients, and they will contact the patients and troubleshoot any issues if they're struggling to get their bloods done.
Right. We know this is very challenging and it takes a lot of time to manage. And when we talk about this disease, there are some psychosocial aspects, particularly when we psychosocial burden of thyroid disease is how do you assess this in clinical practice? And what support pathways are available for patients who are suffering from this disease?
Thank you for that question. Yes, we know that even patients with mild disease can experience significant negative impacts on their activities of daily living and psychosocial well-being. In our clinic, as a screening tool, we use the GO-QOL questionnaire, which is the Graves ophthalmopathy questionnaire, and it results in two scores. It helps clinicians to understand, firstly, the impact of thyroid eye disease on people's lives with the visual function score, and secondly, the psychosocial effects with the appearance score. Patients who score low results, we flag to their GP for counselling, and we try and offer them support through our iClinic liaison officer. And we also have other resources in clinic that we can give to the patient. It's also useful to repeat these these scores after any interventions to see what the overall impact of the treatments have been on the patient's life.
All right. One thing nowadays, everybody talking about artificial intelligence. It is revolutionizing the medical field also, particularly regarding to this field of thyroid eye disease management. How do you see that intelligence is going to help us, benefit us? How do you see the future?
That's a really good question. I mean, AI and health tech conversations about this are everywhere at the moment, and they're such hot topics and really can't be ignored. We already know that AI and deep learning models can analyze CT scans, MRIs, and even patient facial photos to detect characteristic orbital inflammation signs. And there are even chatbots which can help with patient education. However, there are some potential challenges for AI and thyroid eye disease, as there is still the lack of very large data sets, and tools would need appropriate validation. As for its future role in thyroid eye disease, what I would like to see is it get to a point where it could accurately map out a patient's individual Rundle's curve, which would enhance precision medicine by helping clinicians use targeted therapies in the right patients at the optimal time point.
Well, Dr. Mansfield, thank you very much. I know you are very busy with your patient management, research work, and all these activities. So I want to thank you on the behalf of our audience for educating them and answering our questions. And it was, if I say it was a very focused presentation on the practical aspects of the management, and you also covered the latest and current updates in it. We will be looking forward to more presentations on this very specific field with our surgical colleagues, with you also, to see how surgical intervention can also be employed and when it is required. So later on, we will also cover that thing. But I want to thank you on the behalf once again. Thank you, Dr. Mansfield.
Thank you very much.